All right, I guess people are still filing in, but why don't we kick it in gear? Welcome everyone to this edition of National Journal Club from the ACMT. Is a very exciting topic, CT for the evaluation of caustic ingestions. Before I introduce our speakers, a little housekeeping. Remember, if you're out there in the Twitter sphere and you're generating some conversation, use the hashtag ACMTNJC. And also between articles and at the end, if you would like to speak, just raise your hand. And also, please, folks, let's get the chat rolling. Please send in comments and questions for our presenters. So, and yet, without further ado, I would like to introduce the VCU group fellows, Andrew Chambers, Emily Kirshner, Natasha Tabarin, and we are two faculty members. I see the good Dr. Brandon Wills. I don't know if Dr. Kirk Cumpson is hiding there in the background. And then, just because the leadership of this program are former Toxicon grads, I have to show my biases. Dr. Wills was the Scandium Fellow. We have a taxonomy of our fellows, and he was named that. And Dr. Cumpson was a potassium fellow. I don't think Dr. Wills ever really embraced his element, but what can I tell you? All right, with that, please go for it. Thanks, guys.
Thanks, Steve. Yeah, it's not a very cool element. So Happy New Year, everyone. I see that we have 83 participants. Is that a record, Steve? That's pretty impressive.
It's pretty strong. So thanks everyone for joining.
So, yeah, Happy New Year. This journal club was the genesis of it was based on this idea of whether or not CT could have any role in evaluating caustic ingestions. And this is just a fictitious case, but if you were consulting at a poison center and you had a caustic ingestion at a small hospital that didn't have a lot of endoscopy resources, could you use CT alternatively to further evaluate these patients? And so just think about that question. We have a few polls to start off the journal club just to see where the group is at. Steve or Alex, if you can fire up this poll. So if you have a symptomatic caustic ingestion, what is your current recommended diagnostic approach? I don't see any poll coming. Oh, there we go. So endoscopy only, CT only, endoscopy and CT always, or endoscopy plus or minus CT. And I obviously can't control bringing up the results, but if you can, that'd be great.
Yeah, got it. We'll close that out. And that's pretty interesting. 24% endoscopy only, 4% CT only. Endoscopy and CT always 6%, and 66% are endoscopy plus or minus CT, depending on severity.
All right. Cool. Would the group be open to a CT only strategy with GI just following up as an outpatient?
Got that launched. All right, and a little more bias towards no, but 41% said yes.
Oh, all right. 41% were at least open to it. All right. And then this is not related to our journal club, but we talk about this so much and just curious what the rest of the country is doing. Do you guys recommend steroids for grade 2B burns? And you can see the answer choices there. I have a feeling I'm going to guess the right answer here, but put down what your group typically does.
All right, give it one more second. There we go. And I think I'll share that. People should see that now.
So I guessed correctly. GI does whatever they want. All right, cool. Well, we will get into this now. I don't think we have any specific bias in our journal club. We tried to look at these articles dispassionately. I don't have any agenda here. We do sometimes call the CT the donut of truth. Sometimes in the Army, we called it the answering machine. But let's get into it. Also, a couple of background papers. One is there's two reviews that are fairly recent. This one here by Chirka et al. This is a French group, and there's a few interesting things about this review article. The first interesting thing is, from what I can tell, they're all cardiothoracic surgeons, and they have a very specific practice in Paris of and I believe it's a referral center where caustic ingestions get referred to these folks. So that's one interesting observation. The other one is that they basically just blow right past any idea of worrying about steroids or antacids or PPIs or any other therapies. They purport a CT only strategy, and Emily's going to get into that on the third paper. But you can see here, they start with a CT scan and take grade 3 CT injuries straight to the OR. They basically say plus or minus endoscopy before discharge, which might help predict strictures, but they basically have done away with endoscopy at their center. The other paper to contrast this approach is Bob, Michelle, and Sophie's paper. And I don't know if either of these three are on the Zoom today, but love to hear more of their opinions after we review some of these papers. Now this paper is a little more tox centric. There's 3 toxicologists here, no GI, no surgeons, and their biases may be a little different, but here's the approach from their paper. It's very much an endoscopy centric approach. And as you look to the right of this algorithm, it's basically endoscopy first with the more severe burns, recommending CT scan and possibly surgical consult for the more serious ones. So with that background, we will jump into our articles, starting off with Natasha, and take it away.
All right. So our first section will look at CT predicting the need for surgery. And this article was actually not included in the articles we sent out, but I do want to discuss it because it does provide some historical context and also a framework for the articles that we will discuss. And this was by Lurie et al. In 2013, and it was a study out of Israel. So overall, their objective in this study was to evaluate the role of chest and abdominal CT in assessing the severity of acute corrosive ingestions. And the way they looked at severity itself was by looking at mortality and the need for emergency laparotomy, which was defined as any perforation, peritonitis, or necrosis, either on physical exam, the CT, or the endoscopy. And this was a retrospective chart review. They searched hospital ICD-9 codes, and they looked at adult patients greater than 18 years of age. They looked at both intentional and unintentional corrosive exposures. And the inclusion criteria was any patient that underwent an abdominal and chest CT and endoscopy within 48 hours of admission. For the endoscopy, they graded according to Zargar criteria. And for the CT scans, they did the grading based on what's listed on the slide here. And they would look at the worst damaged organ to decide the CT grade. And the CTs were looked at not only by an ED radiologist, but they also were looked at by a GI radiologist. And interestingly, the correlation between the ED radiologist read and the GI radiologist read was only about 57% in concordance. So they reviewed about 300 patient charts, and they found 23 patients that met their inclusion criteria. And interestingly, the acids were the most common caustic ingestion, and 18 cases were intentional. And overall, they had 7 patients, so about 30% of their patient population that underwent an emergency laparotomy. 6 were found to have very severe injury during surgery, so esophageal or gastric wall necrosis, and only 1 of them was found to have a hyperemic gastric wall. And 5 patients, so about 21%, did expire during their hospital stay, so a very sick patient population. And then this table in the paper shows the correlation between their endoscopy grade and their CT grade. And I highlighted a couple of cases that were a little concerning. So they found about 8 patients that had a CT grade 1 that actually were found on endoscopy to have a grade 3 or above. And the ones I highlighted are ones that had CT grade 1 with endoscopy grade 3, and some of these patients actually died. And the last 2 patients, number 22 and 23, they were unable to perform the endoscopy because of severe esophageal edema. And one of these patients had a CT grade 0 and actually died as well. So a little concern in there too. So overall, this paper showed that CT tended to underestimate the severity of corrosive injury when performed within the first 48 hours after injury. And they found that CT is much less sensitive and more specific in predicting severe outcomes. And they did feel that the CT looked at other organs that was not seen initially on a presentation for these patients, for example, like pulmonary infiltrates or splenic involvement too.
All right, thanks for that, Natasha. So the first study I'm going to cover is actually going to be the one by Chirica et al. But again, to give a little bit more historical context to this, this is a different study published about a year prior to the one that we're going to cover in the Journal Club today. And you can see the title of it here. The purpose of it was to evaluate the use of CT for patients that had endoscopic confirmed grade 3B esophageal necrosis in the role for emergent esophagectomy. So they did this using a before and after study design. Prior to 2007, all patients that had endoscopic 3B findings underwent esophagectomy routinely, whereas after 2007, esophagectomy was only performed when there was endoscopic findings as well as CT findings of full thickness necrosis. Now, their primary outcome was overall 1 and 3 year survival. For the endoscopy group, it was 76 and 66% respectively, whereas in the combined group, it was 88 and 83% respectively. Importantly, they had no deaths in any of the patients that they managed non-operatively, and so that they concluded was that CT was safe and reliable for grade 3B caustic injuries, and that CT overall minimized surgery. That's a very radical surgery and therefore improved patient survival. Now, the study itself had several limitations, obviously the study design being before and after. This group tends to have very rapid time to endoscopy. It was approximately 6 hours in this study. And overall, the patients were pretty healthy and stable in good condition. Lastly, they lacked radiological evaluation of low-grade injuries. And so the concern here would be that CT might overstage these low-grade endoscopic injuries. And that brings us to the first study that we'll cover in the Journal Club today. Again, the same group, Chirica et al., published in 2016, titled Computed Tomography Evaluation of Esophagogastric Necrosis After Caustic Ingestion. The purpose of this was to assess the role of CT for emergency management of caustic injuries. Now, different than the prior study, there was no particular group. This was all comers to the emergency department. And so what they did was a prospective study where they enrolled all patients consecutively that were greater than 16 years of age between March of 2013 and December of 2014. And I want to point out that the prior study I mentioned ended in 2012. So this is a different cohort of patients. Now, they excluded patients that were peritoneal or hemodynamically unstable. Presumably, these patients would be perforated, so they would just go emergently to the operating room. And their primary outcome in this study was digestive necrosis as confirmed by path report. And we can look at the study protocol that they did here. So they enrolled 120 patients. All patients that were enrolled underwent endoscopy followed by CT scan. And again, I want to point out that in this particular group here in France, they have pretty rapid time. In this study to endoscopy and CT was approximately 8 hours after ingestion. Additionally, as Dr. Wells pointed out, there's no standardization in this particular group when it comes to adjunctive therapies like steroids, PPIs, antibiotics, or antihistamines. Now, the management decision based off endoscopy and CT had to do with whether the findings were concordant or discordant. So if we look on the left here, we can follow that down. If CT showed necrosis and endoscopy grade 3B, these patients were managed emergently in the operating room. Whereas if the CT showed no necrosis and endoscopy was grade 1 to 3A, these patients were managed conservatively. And this accounted for the majority of patients, 101 out of the 120. Whereas if we follow this diagram to the right for the discordant findings, you'll see that there's 19 patients had endoscopy grade 3B findings, however, no findings of necrosis on CT. And interestingly, no patients, so 0 patients had CT necrosis with endoscopy findings of grade 1 to 3A. All of these patients, regardless, were going to be managed conservatively. Now, they defined full thickness radiologic necrosis based off 2 of the following 3. So they had to see at least esophageal wall blurring, periesophageal fat blurring, or an absence of post-contrast esophageal wall enhancement. Again, they needed 2 out of those 3. And CTs were read by 3 radiologists, which including 1 resident, which I think is pretty applicable to a lot of academic centers. And I was happy to see that. Now, some patient characteristics I just wanted to highlight here was that 88% of these patients were suicide attempts, and 63% of these patients ingested strong alkalis, with the remainder being pretty evenly split between acids and bleach. Now, again, their primary outcome was surgical pathology, and they found that 9 out of the 11 patients that underwent esophagectomy they had confirmed transmural necrosis. But I think the money for us as toxicologists is probably more on the secondary outcomes. So 13% of the patients that underwent surgery ended up dying, and 65% experienced postoperative complications. We could compare this to the group that was managed conservatively or non-operatively, and 0 of those patients died, and only 14% experienced complications. And that includes the 19 patients that had grade 3B findings on endoscopy, but no CT findings. And I also want to applaud them for calculating a kappa for their radiologists. And they found that for esophageal necrosis, it was good at 0.73, and for gastric necrosis was excellent at 0.8. They did some additional analysis, and they found that a CT-only strategy used to select patients would have resulted in 1 unnecessary esophagectomy and 7 exploratory laparotomies. But if we compare this to an endoscopy alone group, it would have resulted in 20 esophageal resectomies and 23 XLAPs. Again, importantly, CT never indicated full thickness wall necrosis in patients that had low-grade endoscopic or less than 3A esophageal or gastric injuries. So in their discussion, they again just reiterated and highlighted that 0 patients that underwent conservative management ended up dying in their study. And so what they concluded was that CT was better for selecting patients for surgery, in that low-grade endoscopic injuries never had signs of CT, or never had CT signs of necrosis, and endoscopy never rectified a wrong CT. Additionally, a CT-based algorithm from their study would have saved or prevented 19 esophagectomies and 16 XLAPs. And so they concluded, they ended their study by saying that CT-guided non-operative management prevents treatment-associated mortality. And again, this is a very radical surgery associated with a lot of morbidity and mortality. So if we can accurately predict who needs surgery, we can hopefully reduce or improve overall survival. And this led them to develop a new algorithm where it was CT-based only. And so that's what they ended up implementing in their hospital after this study. And it's pretty simple. You can kind of see it here, where if there's CT findings of necrosis, then those patients are managed operatively. And if there's no signs on CT, then they're managed conservatively. So in conclusion, I think it's a pretty well done study that builds from the findings of their prior studies. They have a very high number of caustic ingestions, especially in about a year and a half. They have a very rapid time to endoscopy and CT. I would have liked to see them standardize steroids, PPIs, antihistamines, and all those adjunctive therapies that I think most people do. And then additionally, it's not something that their study was looking for, but you would have to imagine that a CT only strategy would probably be more cost effective compared to mobilizing the endoscopy suite and all the resources that that takes. However, I would like to see some external validation of this study, especially given the high number of caustic ingestions that this particular group sees with a very rapid time to CT and endoscopy. So I don't know if there's any questions, Dr. Axe, in the chat, or anything I can try to answer for people.
And nothing in the chat right now. If anyone does have a question, drop it in there or raise your hand, please. Just one observation. It's really interesting, the difference in the Lurie paper where the CT missed significant injury, whereas in the hands of this group here in France, it was much better. I don't know, any thoughts on that discordance?
Yeah, and that's why I would like to see this done elsewhere, because exactly the point. I mean, they have a lot of injuries here, but they're obviously more experienced maybe than the other group, but that's definitely an interesting point.
Right. Craig Smolin asks about MRI as a possibility. I know that's a great question. We had talked about it in our own group. I don't think we have anything in these papers. Any thoughts on the MRI?
Yeah, that would be awesome. I think for a lot of centers, getting an MRI can take a lot of time, whereas CT, I think most centers can get it done more rapidly. But yeah, that would be awesome to see someone try to at least study that.
All right, excellent. Why don't we keep pressing on?
Awesome.
All right, our next section will be looking at CT predicted stricture formation. So this is the Ryu et al. Paper published in 2010 in Clintox, and it was a study out of Korea. And their main aim was to test the utility of CT gradient system compared with endoscopy for the association of development of esophageal strictures in patients with caustic ingestions. And the way they evaluated esophageal strictures was through an esophagram. And they also wanted to develop a new severity score for CT gradient and test this. So this was also a retrospective case series. They reviewed about 61 charts and they found 49 patients that met their inclusion criteria. And this included patients that underwent HSCT within 72 hours of a caustic ingestion. And they also had an esophagram done before discharge to assess for any stricture. And a stricture was defined as any fill-in defect or extraluminal compression. This was done through a barium swallow, and the CTs were done with IV and oral contrast. And this was the CT gradient system that they developed. They actually based this gradient system on studies that have looked at esophageal cancer. And the gradient was done by a consensus of 2 experienced radiologists. They did not specify the background of these radiologists, but they were blinded to any clinical data. For the endoscopy gradient, they actually did not use Zargar's endoscopy classification. However, there are some similarities between this classification that they used and Zargar. So just some demographics of the patient population in this paper. The median hospital stay was about 36 days. The mean age was about 52. Most were female and most were suicide attempts. And the most common caustic substance that was ingested were acids in about 71% of these cases. And kind of similar to Andrew's paper, there was no standardized care regarding the use of antibiotics, H2 blockers, PPIs. So overall, there were 14 patients, so about 29% that received hydrocortisone, but there was no standardized dose or duration of therapy. I also put on here their median time from time of ingestion to diagnostic testing. So CT took about 17 hours, their EGD took about 12 hours, and their esophagram took about 28 days. So overall, they found that 17 out of 49 patients, so about 34.7%, developed strictures. And on this slide, I put the endoscopy grade and the CT grades, the number of patients that were diagnosed with this, as well as the percentage that developed strictures in each grade. And the only factor that this paper found that was significant in developing esophageal strictures was a CT grade 4. So the investigators generated ROC curves to compare CT and endoscopy gradient. And they found that with CT gradient, there was more area under the curve. And they felt that the sensitivity and specificity of CT was higher than endoscopy gradient. However, this was not statistically significant. So their overall conclusions was that CT gradient is useful for estimating esophageal strictures. CT did have a higher sensitivity and specificity, and CT is pretty rapidly available, safe. And they also felt that the delay in CT, so CT was about 17 hours compared with the EGD, which was about 12 hours. It allowed for more swelling and damage to occur so that they could see that on the CT scan too. So just some comments about this paper. It's kind of limited based on its retrospective design. There's also a spectrum bias. So these patients are pretty sick because they underwent endoscopy and a CT scan. The most common caustic ingestion type in this paper were acids, where in the Western nations, it's more alkali, so might not be applicable to our patient populations. Also, the median time to esophagram was about 28 days. A lot of the papers we reviewed, it said that strictures can take up to 4 months to form. So maybe they just missed a bunch of strictures that formed later on. There's also risks of radiation exposure with CT scans. And there was also no standard treatment with antibiotics or steroids. So this could have influenced the stricture formation as well. Any questions about this paper or comments before we move on to our next one?
And thank you to Bruce for the handy information to order your glacial acetic acid in Amazon. Excellent. That is very interesting. The proportions of what 71% were acids. Definitely, I think our clinical experience here is definitely tipped towards the alkali. So yeah, that is interesting how that would factor in.
All right.
Okay.
All right, so moving on to our final paper. This is from the same group in Paris, France, the cardiothoracic surgeons that Andrew presented earlier. By the time of Andrew's paper, they were looking more at whether or not endoscopy was needed to determine which patients should be taken to the operating room. And by the time they started looking and published this paper, they had already taken CT, or they were using a CT only strategy for the operation patients. And now they were looking more for endoscopy for strictures to see if they still needed to use endoscopy. And the objective for this was to look at the endoscopy and compare it to emergent CT and predicting stricture formation after caustic ingestions. Their methods were a retrospective chart review. They included adult patients greater than 16 years. Their inclusion criteria was anybody that came in with a caustic ingestion that got a CT with IV contrast of the neck, chest, abdomen, as well as endoscopy within the first 3 to 12 hours. Their exclusion criteria were patients that had a grade 3 esophageal injuries, because according to their protocol, all of those patients went immediately to the operating room. And they used the Zargar criteria for all their endoscopy studies for their CT grading. They did use a similar study or grading system as what Andrew highlighted earlier. However, for this paper, they had a GI radiologist look through the CT grade 2s and further differentiate them. And they further differentiated them based on whether or not there was post-contrast enhancement. So if the tissue was viable, then there would be contrast enhancement, whereas if there was any evidence of necrosis, there would be no enhancement. So you can see here, they have the CT grade 1, and then the grade 2A and 2B. And of course, the 3s were the ones that they took immediately to the operating room. So in order to define what a stricture was, they followed up in the timing of the formation of them. They followed them up for 1, 6 months, and 1 year. They defined the stricture as an esophageal narrowing that caused swallowing difficulties. And they used endoscopy and barium swallow on these patients. So overall, they were able to include 152 patients. The majority were men, and similar to Andrew's paper, the majority were suicide attempts and intentional ingestions at 89% of their cases. And the majority of these were also strong alkalis with 63%. For their results, continuing table 1, just showing the range of endoscopic Zargar criteria grading system, and then the CT grading system, how many they had in each group. So overall, they had 37% of patients develop esophageal strictures, and all of these occurred within 4 months of ingestion. They had very good follow-up for all these patients, and they even say later on that they were able to follow them for up to 10 years in some cases. And they had 19 patients overall that failed to recover any nutritional autonomy. And I included this because I think it highlights the importance of why we care about predicting patients that will develop esophageal strictures, because it can have very large morbidity. And when they looked at all their data to determine if there were some characteristics of these ingestions that made it more likely to form esophageal strictures, the statistically significant risk factors they found were any patient with psychiatric diagnoses, any strong alkali ingestion, and then interestingly, any severe oropharyngeal injuries were more predictive of strictures. And when they went to calculate the risk of developing stricture formation and with their endoscopy compared to their CT grading, you can see with endoscopy, the risk started to increase with 2B grades, whereas in CT, the 2A and 2B had the higher risk, with 2B being 83%. They did calculate a sensitivity and specificity with CT for the whole esophagus, sensitivity of 86% and specificity of 75%, which is okay. And overall in their discussion, they say that strong alkali was predictive of esophageal strictures in their patients, and that CT outperformed endoscopy in predicting strictures. However, if you look at their data, they do specifically calculate this at 120 days post-ingestion. And in their other time periods, it does appear like maybe they're more similar. And the authors actually go on to discuss how they completely eliminated emergent endoscopy in their protocol for any caustic ingestion. And now their protocol is to CT them in 3 to 6 hours post-ingestion. And then based on their CT grade, if they have a grade 3, they take all of those patients to the operating room. And they now only do endoscopy on demand as needed as an outpatient, or if the patient has any swallowing difficulties. Overall limitations with this paper, similar to the others, where it is a retrospective design. They did have the gastrointestinal radiologist retrospectively grade these CTs, and similar to Natasha's paper, the Lori paper, they only had about a 50% agreement between the ED radiologist and the GI radiologist. And then of course, there probably is a little bit of bias because this group had already eliminated endoscopy from their protocol even prior to this being published. This was published in 2019, and they eliminated endoscopy from their protocol in 2015. So does anyone have any questions about that article before I try to bring it on home with our summary?
Great presentation, really fascinating paper. And it is so interesting. CT alone is I think that's a unique way of approaching this. Any comments from the audience? I know Paul Wax, did you want to jump on and say something?
Yeah, okay, can
There we
you hear
go.
me okay?
Yep.
Okay, great. Yeah, great presentation. Yeah, this topic of the cost of congestions has been near and dear to me for 30 years now. I've always felt that the toxicologists, can have the opportunity to play kind of the quarterback in terms of managing these cases. They're very unusual cases. Most surgeons and gastroenterologists have very limited experience. They may see a case once in a blue moon, and then as the medical toxicologists with more experience, we really can help direct the treatment by these various specialists. Some of the worst and most tragic cases I've seen over my career have been caustic congestions. I have a couple comments. One is you mentioned in the Korean study the preponderance of the acid ingestions, glacial acetic acid. Well, for those of you who enjoy Korean food, and particularly kimchi, there's your answer. And that Koreans often pickle their vegetables, and to pickle their vegetables, they use glacial acetic acid. And in Asian countries, pickling is quite common. I spent several weeks in Russia a number of years ago, and we had the toxicology center I was posted at, we had one bad caustic congestion every day. It was really unbelievable, and it was all glacial acetic acid, and that's because of home pickling. People keep glacial acetic acid, in their kitchen cupboard, which is 70% acetic acid. And at least in Russia, where there's a lot of drinking of vodka, the clarity of glacial acetic acid and vodka are similar. So someone reaching for the bottle of vodka may accidentally reach for the glacial acetic acid and develop a terrible caustic injury. So that was fairly common. That's why it's not surprising for the Korean demographics as is. In my experience as well, with severe caustic congestions, whether it's an acid or an alkali, it doesn't really make a difference. They're both devastating, and they both can affect both the esophagus and the stomach. They need not be a predominance for one or the other. What I'm curious about, and I don't know, it may be too difficult to set up a polling question, is whether the approach to these cases, particularly with CT alone, has penetrated a lot of the toxicology practices and institutions where a medical toxicologist is stationed at. Traditionally, we would go to the gastroenterologist first for the endoscopy. We might get a CT scan as well. But I'm just wondering, from those of you on the webinar, whether your centers have gone to CT alone, and also if you've gone to CT alone, in terms of your selection of consultants, whether you're still getting a GI consult, whether you just get a surgical consult for those with the grade 3, and for those that less than grade 3, you don't even get a GI consult, or whether you might get a GI consult just to have them on board, but not to do the endoscopy, because typically when you have a specialist who does procedures like a GI come on board, their first thing to do the endoscopy. So those are some questions perhaps for the audience, and I'd love to get some feedback. Thanks, Steve.
Yeah, thanks, Paul. And yeah, appreciate the insight to why there's the glacial acetic acid in Korea. That makes a lot of sense. We do have a poll question coming up in a little bit, and we'll actually get a specific answer to, it's framed in one way, but if people do have experiences related to what Paul is talking about, please drop that in the chat as well. And then there are a couple of questions in the chat. You folks at VC want to field those?
Sure. Let's see.
A few of these Emily will address in her summary, like whether there's protocols and stuff like that. What was the other question?
Was that multivariable logistic regression?
In the table that you showed, in the last article, the logistic regression with multiple variables, was that or each of those bivariate, or was the whole table one big multivariate analysis?
Oh, for this one,
Yes.
That's
I-
univariate.
univariate. Yeah.
Okay, so that the problem with that is that, of course, the strong alkali is related to severe injuries, probably. So it's very difficult to interpret what the odds ratio of 2 is. That simply all mediated by more severe injury, or is there something about alkalis independent of the level of injury, apropos of the comments before on acids? And I would also say that this subject probably would lend itself very well to a systematic review and meta-analysis if any fellow was so inclined, because you could pool the data for alkalis if you can get the data stratified from the acids.
Yeah, those are definitely interesting comments. That would be interesting to look at.
Okay, great points. And Kevin Osterhout has an interesting question about how this would apply to pediatric patients. And I definitely think we'd probably look at it with a different lens. Do you folks have any comments from VCU?
Yeah, at least all of these, like none of these papers looked at pediatric patients. They were all adults. So it's harder to apply these papers to, and I think even in the, one of the review articles that Dr. Wills mentioned earlier on, they say directly that they don't apply any of this to pediatric patients for the Chirica group.
Great. And then I appreciate Michael Moss's question, which I feel is unanswerable. Do you guys want to have a comment on that?
Is that the
Thanks, Mike, for that question. I appreciate it. The short answer is I have no idea. I mean, you could look at the highest degree of stricture risk with the CT grade and then just arbitrarily say that's who we're going to use steroids in. But the more important question is, should we be using steroids, which wasn't really the thrust of this journal club. I mean, that is a different journal club actually, is to say, is that even worth doing? So, but that's a great question. Yeah,
that Anderson paper, I guess that's the group that was underpowered, so we still don't know. So yeah, we'll bookmark that for another journal club. All right, do you want to move ahead with the summary?
Yeah.
Comments? Great.
So just a few slides, kind of, we met a couple times to try to wrap our heads around this journal club and figure out if this was going to change our management of caustic ingestion patients. We had a couple things that we thought were important to note. So one is that obviously all of these papers had different CT grading criteria, and there's no one standardized criteria. For grade or the lowest grades, they tend to be about the same, like there was no esophageal wall thickening and no evidence of necrosis and overall normal. And the most severe would be similar as well, with just necrotic esophagus, but the ones in between the moderate grades were all very different. So it's an important thing to note when looking at these studies. Then our overall nuggets, as Dr. Wills will say, from this journal club, were that CT is a very valuable tool, and it may be helpful for identifying patients that need emergent surgery, especially in those institutions where you have issues getting endoscopy quickly. But overall, there is no consensus on CT grades, and we found from talking to some of our radiologists here that they weren't even aware of these studies or the grading scales. So there's not a lot of awareness. And of course, these injuries or these ingestions, often you have tox involved, sometimes GI, as well as CT surgery. So it is definitely a group effort to take care of these patients. And then CT may prevent unnecessary surgery based on endoscopy grade. The group out of France definitely highlighted this in their article. And then CT might miss serious injuries, which is a very scary thing to possibly miss a high-grade injury, as the Laurie et al. Paper displayed. And then stricture formation is delayed and may be diagnosed as an outpatient is an interesting idea if we are able to do endoscopy more as an outpatient rather than an inpatient. And then none of these papers specifically address the intent or symptoms. They do look at whether or not they were suicidal attempts or not, but we can't get a whole bunch of data or conclusions based off of it. So our overall summary was that CT could be a very useful alternative or adjunct to the endoscopy evaluation for caustic ingestions, but overall more data is needed and more trials. So going back to our poll questions, just to see if anything in this journal club has changed anybody's idea or approach.
Okay, so that should be launched. Give it 1 sec. Okay. So we have 70% would choose endoscopy plus or minus CT depending on severity, 15% endoscopy plus CT, and 11% CT only, 4% endoscopy only.
So it's about the same, I guess, as it was before. Maybe some people more on the CT. And then to our second question. So would you be open now or more open to a CT only strategy than you were before?
Alrighty, we're almost split down the middle, a little more towards the nose.
Interesting.
Yeah, it's an interesting question because I guess one look is for severity, the other look is for risk of strictures. So I guess outpatient GI follow-up may mean different things to different people.
Yeah, and I think our overall kind of conclusion and thoughts on this journal club were that we do think that CT would be a great addition to looking at these patients, especially if you're in like your freestanding ER or a poor resource environment, or you can't get an endoscopy quickly. But I don't know that we would completely replace endoscopy.
The other issue that we had was, or that we've talked about, was that until there is some standardized training for radiologists that even know that this exists, it's probably premature to employ that as your primary diagnostic algorithm. We had a case a few years ago where the radiologists were only reading the CT through the context of looking for mediastinal air. They weren't even looking for esophageal injury, so it was not even addressed on the CT scan. So we definitely need more consensus with our colleagues about how to read these.
Absolutely. I appreciate Sarah Watkins' anecdote, which is very concerning, about the initial CT read as normal, yet there was ultimately endoscopy showed extensive necrosis. That's very, very disturbing. And the other, oh, Paul, did you want to speak again? I'm not sure if your hand's up again or if that's from before.
Yeah. Hi, Steve. Yeah.
Yeah.
I think with the more extensive injuries, early CT is, certainly I would recommend early CT. In addition to the endoscopy, I realize some of your all reluctance about abandoning endoscopy and maybe abandoning endoscopy is, we're not quite ready for that. Although endoscopy itself has its own complications, it's certainly more invasive than just the CT scan. But I took care of a very sick caustic years ago who had the endoscopy within the first 12 hours, there was bad looking necrosis, blackened necrosis. They decided to watch the patient, under the care of the general surgeon. They did not get a CT scan. And then the patients developed a fever on day 3 and 4, and then a little bit of acidosis. By the time they took the patient to the operating room, the esophagus was pretty much gone, and the patient died within a couple of hours after the OR. If they'd done an earlier CT, they might have gone. They may have operated earlier. So I think with endoscopy that shows a more limited injury, you may not have to get a CT. But if there's a grade 3 injury on endoscopy, I would definitely get a CT, and then potentially serial CTs.
Yeah, that's interesting with the serial CTs. I really appreciate Sarah's comment saying that the CT was done early in the ED, endoscopy much later. So you do wonder, if you do it too soon, will you miss some really significant injuries?
Yeah, and it obviously it gets worse over time. That's why a lot of these deaths, they don't occur in the first day; they occur day 3, 4, 5, because the mucosa, or the whole structure softens up over time, and they perforate 72 to 96 hours afterward.
Exactly. And Ingrid Vikas also has an excellent point that this has to be multidisciplinary. And, I think that we have to go stepwise before we institute this in our own shops. Any other comments in the chat? I don't see anything else. Oh, Michelle Heiger has a question. Have you ever seen them do a surgery to prevent perforation?
I don't know who that question was directed towards, but clearly the surgeons in France are aggressive, arguably way more aggressive than any of us are used to seeing in the US. And they are doing just that. They're taking pre-perf, totally necrotic cases and resecting out diseased parts and doing crazy radical surgeries. But the bad case that we had a few years ago here, it was not aggressively treated, and the patient perfed and died 20 days into their hospitalization. And so I guess, Michelle, it depends on your institution and how aggressive your surgeons are. Ours here for that N of 1 was not very aggressive.
Michelle Burns, I see you have your hand raised. Go ahead.
Oh yeah, I just wanted to say hats off to the VCU crew. That was an excellent journal club. I really appreciated hearing from all of you. And we did have a letter to the editor after we had published our review, to which Bob Hoffman was quick to take pen to respond, quote unquote. But we did just emphasize the importance of the direct visualization to see the thickness of the injuries, which is not appreciated commonly on CT, to see what medical therapies could potentially be instigated in order to mitigate further damage. And so it was that importance of the direct visualization by endoscopy was what our response to that letter to the editor was. It's certainly acknowledging the ease of access and rapidity of CT, but again, just that direct visualization with endoscopy. And I did appreciate that comment in the chat box about now the surgeons at that one particular institution are actually credentialed to do endoscopy, since at least at our facility, it can be somewhat challenging sometimes to get a hold of GI in the middle of the night.
Great, thanks, Michelle. All right, well, that was a fantastic presentation. Do you guys have any wrap-up comments?
Just thanks for the invite, and nice to start off the new year with everyone, and look forward to more.
All right, well, thanks so much to the team at VCU, Andrew Chambers, Emily Kirshner, Natasha Tabaran, and the good Dr. Brandon Wills. Our next National Journal Club will be March 8th at the same time, and that will be hosted by the WashU folks, led by Dr. Schwartz. So with that, thank you so much for joining, and we will see you next time.